So tonight's talk is entitled A New Approach to the Annoying Cough That Does Not Go Away. And this is certainly very topical at the moment because patients with cough feel more self-conscious now than they ever have before. The concern about COVID makes anyone who coughs very self-conscious about that because they feel that everybody thinks that they may be infectious, and that makes the cough, which has always been an annoying symptom, be even more annoying. So to have an approach to this for your patients will be really beneficial, and hopefully will take you through a nice way to approach cough. And then I'm going to talk mostly about the medical side of things, about how to investigate for causes of cough, what are the common causes and what are some of the under-recognized causes, what investigations to perform, what treatments to try. But then we're going to hear from Ali Kavanagh, who's a respiratory physio, who's got an excellent way to treat patients with cough when we're not able to determine what the underlying cause is and when the common treatments are not working, because they're the patients that are really difficult. And Ali's got a great way to share with you that she's able to manage them and help them a lot. So I have a general management approach, and I explain this to patients that I think the first most important thing to do is exclude a sinister cause. And often this is what patients want. I saw someone this morning who was terrified. They were only 23 years old, but they'd smoked a bit in the past, and they were concerned that they had lung cancer as a cause for their cough. They certainly didn't have lung cancer, so being able to reassure them was important. The next thing to do is to investigate for a treatable cause, because if we can identify the cause, then we know what the treatment is. Sometimes we're not able to identify the cause, so sometimes a trial of treatments is useful. And so empiric therapies, certainly have a role. Then if that's not working, what we want to do is employ techniques to improve the symptoms. And that's certainly where respiratory physio plays a great role in helping these patients control their cough. We tend to divide cough into chronic and subacute, and the subacute cough arbitrarily is between the 3 to 8 weeks, and anything more than 8 weeks is called a chronic cough. It's useful because the cause is slightly different. In the 3 to 8 week, we're thinking more likely infection, viral infection, sometimes a bit of post-viral cough. In the chronic cough, we're looking at other causes, and that's what we're going to concentrate more on tonight, because it tends to be more of a problem, because often if people's cough settles down within a few weeks, they don't present for help. Okay, so there are lots of different causes for cough, and I'm sure most of you will know of all of these causes. So I don't want to go through each one of them. Some of them relate to underlying lung disease, and some of them are non-lung related. There are a few of them, though, that I think are more common than others, and I think that it's worthwhile spending a bit of time on because they're common and they're probably a little bit under-recognized. The first one is asthma. Asthma is not under-recognized, but it can be a cause for cough, and sometimes it can be difficult to recognize that asthma is actually the cause for the cough. Sometimes it can be associated with shortness of breath, wheeze, chest tightness, and symptoms that we commonly associate with asthma. However, sometimes cough can be the only symptom of asthma. So someone might present with a cough over a long period of time without the other symptoms of asthma, but it might be actually due to underlying asthma. And sometimes this can explain that prolonged cough. So a prolonged cough after an infection. So, the 100-day cough where someone gets an upper respiratory tract infection and 100 days later, they're still irritated by the cough. So their immune system has got rid of the virus, the fever and the sore throat and everything's gone away, but the cough has persisted. So the most important test in this situation is obviously lung function testing. And so here's an example of a lung function test that we've done just at Bentley. And to interpret this, the most difficult thing is that there are too many numbers on the page. So I just want to draw your attention to the most important number, conveniently located right in the middle, is the FEV1 to FVC ratio. This is the number that tells us if there's airflow obstruction. If this number is less than 0.7 or 70%, there's airflow obstruction. And in this situation, it's 0.61. So that means that this patient has airflow obstruction. The FEV1 then just tells us about the severity of airflow obstruction. And in this situation, at 72% are predicted, so just a little bit reduced. So there's mild airflow obstruction. The post-bronchodilator spirometry shows a significant improvement. There's a 16% improvement in FEV1, which is over 300 mils. So this is a significant improvement post-bronchodilator. And so this would be diagnostic of asthma in the patient who's presented with appropriate symptoms. The management of asthma has become a little bit more complicated because there are so many more inhalers. So I put this slide together specially that you can take a copy of that I find really useful. I still have this next to me in my consulting room because I have difficulty remembering what all of these inhalers are and where they all fit in and which ones are PBS listed for what. But essentially, if we look at asthma, the first line is inhaled steroids. So you can use inhaled steroid by itself, or you can use inhaled steroid with formoterol, the long-acting beta agonist. Then you move on to the regular inhaled steroid with long-acting beta agonist, gradually increase the dose. And if patients are still symptomatic despite taking it appropriately, then that's when we add in the LAMA, and we can either add in Spiriva, or now we can change them to a triple therapy inhaler, Enerzair. If we look at the COPD pathway, the pathway is different because the first thing that we want to do is bronchodilate. So bronchodilation is first line and second line. So we use a LABA or a LAMA, or we combine them together for additional effect. Now, steroid is really only useful in those patients who may also have asthma, those that exacerbate frequently, and those that have eosinophils in their blood. So eosinophil count more than 0.3 tends to suggest that they may benefit from inhaled steroid. And so that's what I've tried to put together, is where all those inhalers fit in. Because when I started respiratory, it was much easier. It was Seretide and Spiriva, and that was it. But now it's become more complicated. So I find this a really useful way to sort of conceptualize where all of the inhalers fit in. Upper airway laryngeal irritation is a common cause for cough, and I think under-recognized. Sometimes patients have allergic rhinitis. They could have a non-allergic, sort of that perennial rhinitis that goes through all year, or maybe vasomotor rhinitis, which is a bit more difficult to treat. Sometimes, the runny nose and runny eyes in response to cold air that tends not to improve so much with the nasal steroids. It's often associated with postnasal drip, but it's not always. And so patients often will describe that they feel the mucus dripping down the back of the throat, but sometimes they don't. And if they don't get that symptom, it doesn't mean that their cough is not due to upper airway laryngeal irritation. Often it's associated with throat clearing. And sometimes you can hear patients do it. You might hear during the consult that, sometimes I'll ask them often, do you feel the need to clear your throat? And often they say, yeah, I do. And they don't feel the postnasal drip, but they need to clear their throat. Sometimes they don't recognize they do it. So you may actually listen to it, and if you pick up on it, they might clear their throat 3 or 4 times while talking to you, but they haven't realized. Or so sometimes you could ask their partner, do you notice that they have the throat clear a lot? Sometimes there's sputum production, especially at nighttime and in the morning. Because during the nighttime when we're asleep, we don't cough. Often that mucus builds up in the upper airway overnight, same as in the lung, but often there's a cough and sputum in the morning, and that may suggest upper airway cause for that mucus, and it may be sinus disease and upper airway problems causing the cough. With regards to investigations, usually the clinical suspicion and history is enough to determine that this is the cause for the cough. So often a trial of treatment is useful, so I'll often start with FES nasal spray or a saline irrigation with or without nasal steroids. Certainly if there's an allergic side to it, or if there's a lot of hay fever symptoms, I'll add in the nasal steroid as well. If there's sinus symptoms with pain or swelling or headaches, certainly a CT scan of the sinuses is helpful. And if there is sinus disease on the CT, that's when we want to treat the sinuses quite aggressively with sprays and nasal washes, but also consider referral to ENT. And I do a lot of bronchoscopy, and I've also do nasal endoscopy in the rooms. And there's a picture of me just using the nasal endoscope, which is just a little tiny camera that slides down the back of the nose with a bit of local anesthetic. And it's quite useful because we can visualize the vocal cords, visualize the upper airway. Sometimes we can see that there's inflammation up around the upper airway on the vocal cords, and sometimes mucus there that can give away the diagnosis. Vocal cord dysfunction is also very common and often associated with upper airway laryngeal irritation. Normally, as we see here in the picture on the left, the vocal cords are relaxed and relax open like this. When we breathe in, they open a little bit. When we breathe out, they just close a little bit. Sometimes, as in the picture on the right, the vocal cords close excessively and they can't clamp down, and that can cause cough. And they may usually do this in response to something. So it may be the postnasal drip, laryngeal irritation. It may be a strong smell, perfume. maybe cold air, or maybe going into the supermarket on the freezer aisle, or to the pharmacy where there's the perfumes. Often is associated with a change in voice, and often these people have normal lung function. So they may get breathless with these symptoms or feel like it's hard to breathe, it's a bit choking, but sometimes cough is the main symptom. And I use this handout, which if you send me an email, I'm happy to send to you to explain what vocal cord dysfunction is. And the initial treatment is really diaphragmatic breathing exercises. And so what I do is I get patients to while lying down, I'll do it while I'm standing up, but with one hand on the chest and one hand on the tummy, get them to breathe. And so as you breathe in, what should happen is that the diaphragm is engaged and comes down, and that pushes the tummy out while it draws the air in. What happens when people breathe in a dysfunctional manner, they pull the air in from the top of the chest using the accessory muscles across the ribs, and they pull their chest out like this. So if you see people breathing, clearly dysfunctional breathing, what it should look like is, or if I look from the side, it should look like breathing in and breathing out. So it's all from the diaphragm. This also is a really good mindfulness exercise. So it's good to relieve anxiety, which is often associated with vocal cord dysfunction and breathlessness. And so by doing this exercise for 5 or 10 minutes twice a day, it can be really effective in stopping the vocal cords from clamping down and reducing cough. Sleep apnea is a common cause for cough. And sometimes patients present with cough and the underlying problem might be sleep apnea. As a matter of fact, 30% of patients with sleep apnea do have a chronic cough. And CPAP, treatment of the sleep apnea, usually improves the cough. It may be related to reflux, because when there's sleep apnea and our upper airway obstructs, and we're trying to breathe through a closed upper airway, we increase our intra-abdominal pressure. And that increased intra-abdominal pressure can cause reflux because it causes the mucus to come up. So it's important to ask about snoring and sleepiness. I think that in patients who snore, if you think about what's happening, their upper airway, which is held open by muscle during the day so that we can breathe in and out through an open airway, is relaxing and becoming floppy and vibrating all night. And then the airway is closing and then opening up and closing and opening up. And this is causing ongoing irritation and trauma to that upper airway. So it gets some swelling and some edema. And so it's no wonder that during the day, that cough is one of the main symptoms. And it's all due to that. It is feeding into that upper airway laryngeal irritation. And so treatment of the sleep apnea, so stopping the snoring at nighttime, can result in reduction or in significant improvement or resolution of the cough. Excessive dynamic airway collapse is an interesting condition and only recently really become recognized as a problem. And what we're looking at there on the screen is a bronchoscope sitting in the mid-trachea with the carina directly in front of us and the right main bronchus on the right and the left main bronchus on the left. The posterior wall of the trachea is muscle and the anterior wall is cut to hold the trachea open. And so I'll play this video for you and I'll show you what it looks like looking down a normal airway during breathing. The bubbles is a bit of surfactant, normal airway secretion. This is the left lung, upper and lower lobe, coming back to the carina. Now we'll go into the right lung and we're looking in the right main bronchus, right upper lobe and down the lower lobes. This is excessive dynamic airway collapse. And so what you can see there, just during normal breathing, the posterior tracheal wall is bowing in so much that the trachea is almost closing. You can also notice that the tracheal airway is quite red and inflamed. And so have a look what happens when the patient breathes in, it'll open up. And then as they breathe out, it just closes. So if that's happening during normal breathing under some anesthetic, imagine what's happening when they're coughing. When they're coughing, their airway wall is just smashing up against each other and causing all that irritation and redness. And so it's no wonder that the more they cough and it potentiates cough and you get into a real coughing fit. And you might have heard this because it causes a real typical sort of barking cough, a reverberating cough. You can almost hear the air as the trachea sort of is vibrating and they're coughing out. So if you do hear it, it's really quite a typical cough. And sometimes as soon as someone walks into the rooms, I can tell that this is what's going to happen. And bronchoscopy is what we do to investigate for it. These patients often improve with CPAP therapy. And so they often use CPAP at nighttime to treat any sleep apnea, because it's often associated with sleep apnea. But then we also get them to use the CPAP during the day for episodes of cough. And sometimes say for 10 minutes in the morning and 10 minutes at night, just to open up their airways, and they get quite significant benefit from that. So with regards to investigations for a patient with cough, I think everybody should have a lung function test and a chest x-ray. Lung function test tells us obviously how the lungs work and will diagnose a lot of underlying lung disease, including asthma, COPD, pulmonary fibrosis, bronchiectasis sometimes. And a chest x-ray will really look for structural abnormalities in the lung. This is our respiratory scientist Kyle doing a lung function test in our rooms in Bentley. If the patient is a smoker, or if there are any concerning symptoms, especially coughing blood or coughing quite a lot of sputum, or if there's loss of weight, or if the cough just doesn't settle down after a period of time and the initial investigations have not revealed a cause, then I certainly think a CT scan of the chest is indicated. If patients are overweight, snore, or have sleepiness, that suggests sleep apnea, so they should have a sleep study. And here I am having my home-based sleep study where I was wired up at our rooms there at Bentley Specialist Centre, ready to go home and sleep to have my sleep study. Sometimes asthma is suspected, but the lung function is normal. And so in a percentage of patients who have asthma, they will have normal lung function. And so in that situation, either a trial of inhaled steroids or a bronchoprovocation test can be useful, because if the bronchoprovocation test is positive, then that confirms asthma. Although the tests are never 100%, if it's negative, it suggests that maybe asthma is not the cause. And if there's no cause identified, or if we suspect excessive dynamic airway collapse, or if there's an abnormality on CT, then certainly the next step would be bronchoscopy to inspect the airways. And at that time, we can also do bronchoalveolar lavage to see if there's airway inflammation, if there's elevated inflammatory cells in the lung parenchyma, and we can take airway biopsies to look for things like eosinophilic bronchitis. There's certainly a role for empiric therapy. So once the sinister causes have been excluded, certainly nasal sprays, and I often use FES or nasal saline washouts and nasal steroids to treat that upper airway laryngeal irritation, postnasal drip, sinus symptoms. Inhaled steroids is useful to a trial, especially if there is a suspicion of asthma. Proton pump inhibitors are often effective in those patients, usually presenting with symptoms of acid reflux. Sometimes they don't get the typical symptoms of reflux, but they may get benefit. There may be reflux that's just causing cough. A trial of antibiotics is useful, and the usual antibiotic I would use is either doxycycline or erythromycin. Erythromycin is a macrolide that has the added advantage of having some anti-inflammatory properties as well. Often I'll put that with a little bit of low dose of prednisolone, maybe 10 or 15 milligrams. And I usually only do that if there is sputum production. For a dry cough, I find that usually antibiotics are not so effective. And sometimes I'll try prednisolone, especially if I suspect an inflammatory cause or asthma. And sometimes people use gabapentin. I don't use gabapentin. There has been a couple of small trials that have suggested that gabapentin can be effective for patients with cough where there's no underlying identifiable cause and they've failed other treatments. However, I think that cough control therapies are much more effective, and Ali is going to talk about those next, physiotherapy techniques that can control cough, and physiotherapy techniques have no side effects. So I would always try that before going on to something like gabapentin, and in the trials they needed quite high doses, so it's not something I've tended to do. So that leaves us with, what do we do when it gets tough and there's no cause identified and there's been no response to the empiric therapy? And this is when people really suffer. It's when they get frustrated. I get frustrated. I'm sure we all get frustrated with when we can't help those patients with that irritated cough, feel self-conscious by it, impacts their quality of life. So what can we do about it? And that's when the cough control therapy comes into play. And I think that the best way to do that is with a respiratory physiotherapist who can go through the process of showing how to do it. So in summary, the most important thing initially is to exclude a sinister cause. It's important to try and identify the cause for cough, because if we can identify the cause, then we know what the treatment will be. The most important tests are lung function tests and imaging of the chest x-ray plus or minus a CT scan of the chest. It's useful to try common therapies that are often effective And if it's effective, then we know what the cause is and we know what to do about it. If not, then we consider further investigations, including bronchoscopy, sleep studies, and ENT reviews. And then if that doesn't work, as I said, cough control therapies is the way to go. And that's where we're lucky at Bentley Specialist Centre and Lung and Sleep. We have our 2 respiratory physios, Leah Jennings, who we've heard from to introduce us, and also Ali Kavanagh, who's going to talk to us now. So I will answer some questions at the end, and thank you very much, Ali, for continuing on and talking about our cough control therapies.
So I'm Alethea, or Ali Kavanagh, and I'm a physiotherapist at Lung Life Respiratory Physio based in Bentley. So thank you for joining us today as we talk about how to manage the troublesome cough that has no identifiable cause, or where medical treatments and interventions have been exhausted. Okay, so I think a good place to start would be to define this refractory chronic cough. It's cough that goes for more than 8 weeks and is unexplained despite extensive medical investigations and treatment. Some of the common triggers can include temperature changes, talking, scents, dust, fumes, or smoke. It's really important to note that refractory chronic cough can coexist or overlay cough due to underlying respiratory disease as well. And it's widely accepted that this is driven by a hypersensitivity and hyperresponsiveness of the cough mechanism. So what this means is, not only do these patients have a lower stimulus threshold to trigger cough, but they also have a greater cough response, or amount of coughing in response to the same dose stimulus compared with healthy adults. So there is a loss of control within this cough mechanism. So we'll review the cough mechanism briefly. There are 2 main sensory afferent nerves involved in these vagal pathways. You've got your C fiber chemoreceptors that line your airways, and they are sensitive to capsaicin, or your chili pepper extract, heat, acidity, and inflammatory mediators. You also have A delta mechanoreceptors that line the proximal airways, and these are sensitive to mechanical, osmolarity, and acidity stimuli. So these receptors then will stimulate nerves that synapse in the medulla, or the brainstem, and from there impulses get projected cortically, and this gives rise to that sensation of throat irritation and the urge to cough. And impulses also travel subcortically, and if strong enough, will activate your spinal nerves that innervate the diaphragm, intercostals, and larynx to actually cough. We also know that cough can be voluntarily triggered and suppressed. So this problem with chronic cough could arise from both the peripheral or central nervous system. So what do we do? How do we manage this chronic cough? We know that there is a lack of suitable antitussive medications and some response to your neuromodulators. But actually, the ERS and CHEST guidelines have concluded that cough suppression therapy, when performed by competent practitioners, can be highly effective. The studies have demonstrated significant improvements in cough measures and quality of life, and cough control therapy can also enhance benefits from neuromodulators. So what does cough control therapy involve? There are 4 main components to cough control therapy. It begins with education, followed by looking at airway health. Breathing retraining is often required, and then arriving at cough control or suppressive techniques. And all the way through therapy, it is underpinned by education, and more education. I'm going to go into a little bit more detail on each of these components, but what I really wanted to convey here is that when you have arrived at this point, many of your patients, and potentially yourselves as well, would have been on a long journey of investigations, medical treatment trials, referrals to various specialists. So when they're getting to this point, patients are often desperate for an answer. They're looking for a fix. And when you discuss cough control therapy referrals with them, it is beneficial to set them up to know that cough control therapy is a process. It's not going to be off you go to physiotherapy and they're going to fix your cough. It is a journey. It requires mastery of skills, which takes time. Right. So the first component, education. We educate our patients about the cough mechanism. They learn that the urge to cough is real, but the need to cough is not real. In fact, coughing has significant negative impacts. And when you delve into it, it's really quite significant, the cost of cough in someone's life. I wonder, how many of your patients would admit to having some level of loss of continence control when it comes to their cough, loss of voice, loss of sleep, or poor sleep, waking up every day with headaches, coughing till they vomit, having chest pain, back pain, cough syncope. And that's not okay. This chronic cough is manageable. Socially, talk about embarrassment with cough these days. These individuals know that their cough is an annoyance to others, and it does interrupt their work and their social interactions as well. Psychologically, it probably comes as no surprise that the research shows that depressive symptoms and isolation are associated with having chronic cough, and patients can still have this concern about underlying misdiagnosis or underlying illness that's yet to be discovered and treated. Financially, chronic cough can cause a loss of work, loss of ability to earn income, but on the other end as well, there can be significant healthcare costs associated with chronic cough. So the cost of chronic cough, really does far outweigh the investments in costs for therapy. The second component, airway health. Now, this is a precursor to delving into cough suppression techniques because you want to address contributors to cough from top to your bottom airway. So if a referral came and the patient had productive bronchiectasis, we want to make sure it is essential that they have an optimized, effective airway clearance regime before trying to suppress their cough. Similarly, we have to manage your sinus secretions or congestion, and that's often looking at a combination of nasal sprays and rinsing, working alongside their medical practitioners. Oral hygiene, so checking that if they are using inhalers, that the technique is not contributing to any airway irritation, and encouraging adequate hydration to reduce that receptor, the irritation of receptor sensitivity. We also check to see that they can avoid irritants in their own environments. Breathing retraining is often indicated because by this point that they come and see us, they often present with a lot of laryngeal and upper chest tension and overactivity. So like Barton mentioned before, typically looking at diaphragmatic breathing retraining can help to mobilize the lower chest and the abdomen, and to de-escalate overactive upper chest and upper airways, and that can help to relax the larynx. It can assist with relaxation of vocal cords. And so I'm not going to delve too much into breathing retraining. That will be a separate talk on its own, and we've actually done that. So I'm going to get Leah to just post in the chat the link to a previous webinar that we did on managing breathlessness, which has more information about dysfunctional breathing retraining. At Lung Life, you'll find physiotherapists who have had additional specialized training in breathing retraining. So Leah and I are both certified Bradcliffe method practitioners. And we're here to help you and help your patients. Okay, the final component being cough suppression and cough control techniques. So the aim of this is to de-escalate your overactive neural pathways, that cough mechanism pathway that we talked about before, and to strengthen the conscious control of cough. It begins with awareness. Awareness precedes action. So we get patients to learn about the behavior of their cough, to be able to identify what triggers it and what happens in the lead up to cough, and how it behaves over the course of day and night. When they can learn that, and when we can discover patterns and triggers, we can then target our strategies. So on the left-hand side of the screen there, you'll see some of the strategies, the cough substitution strategies that we can explore with patients. There is no one type of combination of strategies that will fit all patients. We really explore to see what types of sensations work for each individual, and the combination of these can also change over time. So we begin small. We start with targeting small coughs at a part in the day where they are not too mentally overloaded, but they're also not too fatigued, and their cough symptoms are not terribly severe at that point. So we start with the small coughs, and as their skills gain strength, they increase their awareness, and then we proceed to tackle on bigger coughs for a longer duration of time. So you can see that this is a process, and it is so important that it is underpinned by psychoeducation. We help patients to set realistic goals in realistic timeframes, and to also manage their expectations. We're not going to be looking for a fix for their cough or a cure, but really to get them to be so good at managing this condition. It's really important across the journey that we celebrate achievements, because even small changes in their cough symptoms can make a big difference to their quality of life and what they can start doing. So yeah, that is, that psychoeducation underpinning cough control therapy throughout the whole journey is absolutely, a cornerstone to the success of this all. Okay, so the take-home message, just bring it all together. Really, 3 things. When a patient walks into your rooms and they go, "Oh, I've had a cough for so many years," you have a process to follow now. You're going to know what to do. You're going to run the relevant investigations that Barton has talked about. You're going to identify, treat, or exclude significant respiratory disease. And for the troublesome cough, you can refer to your trained physiotherapist for cough control therapy and breathing retraining if required. So that's all.